Hey, go ahead with the next speaker, please. Dr. Sunil, please.
Yeah, good evening, sir. Let me share
Can
my
you share
screen.
it?
Yes. Hope my screen is visible, sir.
Yeah, screen is visible, but
Yeah, sir.
PowerPoint is not open.
Yeah, now, sir.
Your PowerPoint is not open.
You could keep it open and then share. So please share out and then keep it open and then share again.
Now, is it visible, sir?
Not, yeah,
Yes.
it is.
Yes, sir. Today I'll be talking to you
Go
basically
to full
regarding.
screen, please.
Go to slideshow.
Yeah, it's showing slideshow, sir.
No, I don't think the slideshow is not there.
Technical team, can you help out, please?
Now, sir.
You can unshare and you can stop sharing and then reconnect.
Yeah.
Otherwise, go like that only. Better to save time, sir.
Yeah, sir. Sure, sir. Sure. Now, sir.
Yeah.
Yes, correct.
Okay. So today, basically, I'll be talking to you regarding post-traumatic cyclodialysis, how to manage in cases associated of cyclodialysis clefts with retinal problems. My slides are not moving.
Right from the arrow at the left bottom.
Yeah. Basically, when you evaluate a cyclodialysis cleft, either preoperatively or intraoperatively, you would like to look at the extent of the cyclodialysis cleft and the number of clock hours of the cyclodialysis cleft. Preoperatively, if the globe is intact, one can do a gonioscopy or imaging modalities like UBM and anterior segment OCT can be used for the evaluation of the cyclodialysis cleft. Intraoperatively, of course, scleral transsimulation, and if the globe is intact, you can do an intraop gonioscopy also. If one has got access to endoscopy, one can do an endoscopy to evaluate the cyclodialysis cleft. Coming into the management of cyclodialysis cleft, basically you should look at the extent of cyclodialysis cleft. If it is a small cleft, that is around, if it is less than 4 clock hours, you can think of conservative management, or you can use a laser or a cryo. And if it is required, surgical maneuvers are required. But if it is a large cyclodialysis cleft, if it is more than clock hours, definitely one should consider a surgical maneuver. What are the basic principles of cyclodialysis repair? One is you should bring about a mechanical apposition. Either you should oppose it from the scleral side or from the ciliary body side. That can be done using a buckle or cyclopexy using the sutures, or vitrectomy along with gas and silicone oil. Or sometimes if you are combining with a phaco, you can place the IOL in the sulcus and bring about the closure of the cyclodialysis cleft. The another maneuver one can try out is especially in small clefts, is relieving the tension on the ciliary body using the cycloplegic drops, or using a CTR ring, one can bring about the closure of the clefts. In a very small clefts, one can consider either laser, either argon or diode laser, or cryotherapy can be tried. Basically, the commonest surgical maneuver one plans in repair of cyclodialysis cleft is a cycloplexy, which is either ab externo or by an ab interno technique. Ab externo technique, where in a direct cycloplexy, one tend to do a scleral flaps and scleral cut down and directly visualize the cleft and close it. In an indirect, you can do an without opening the sclera, and you can do transscleral or a transcarneal maneuver. The recently, the commonest technique ab interno used is the sieving machine technique, which I will be showing you. This is a single suture, single knot technique. You can use the buckles, IOL, CTRs, everything I explained in the previous slide. Coming on to the vitrectomy, why one should close the cyclodialysis clefts in vitrectomy is to make sure that the instruments are properly passed into the vitreous cavity rather than into suprachoroidal space, and to prevent an hypotony, and prevents further choroidal detachment during pars plana vitrectomy, and prevents the migration of silicone oil into the suprachoroidal space, and further prevents the post-operative complications during vitrectomy. Direct cyclopexy is not a recommended technique during pars plana vitrectomy because you need to do a larger scleral flaps, multiple incision, and the scleral blood has to be sutured, opened up, and the directly clefts have to be sutured. By this, you can cause the instability of the globe, and sometimes the fluid leakage can occur during pars plana vitrectomy. Let me show you a technique of an indirect cyclopexy, which is done. And after doing a peritomy, you have to we are using a 9-0, do a diathermy. Then take a 9-0 proline suture starting around 1.5 mm behind the limbus, and take a full thickness suture and will come out around 3.5 mm behind the limbus. Once you tie the knot, take a multiple interrupted sutures approximately 1 clock hour apart, or depending upon the extent of the cleft, you can do a multiple interrupted sutures and you have to bury the knot. This is the way you can do an indirect cyclopexy, but the only thing is sometimes this may not involve the full extent of the cyclodialysis cleft because you're blindly taking the suture, and sometimes the cases may fail. Let me show you another technique where is an ab interno technique where 10-0 proline, the first conjunctival peritomy being done in the area of the cleft. You need to cauterize to expose the sclera, make a partial thickness scleral groove approximately around 1.5 to 2 mm from the limbus, make a clear corneal wound, and take a 10-0 proline suture and pass a 26 gauge bent needle from the scleral groove on the other side. So bring out the needle so that it's a double arm suture. Same maneuver can be repeated once again. And from the two ends, when they come out, you can tie the knot into the scleral groove and the knot can be buried. This is another way of suturing doing a cycloplexy for cyclodialysis cleft. During vitrectomy, one can do another method without a flapless, glueless cyclopexy technique using a proline suture and a 26 gauge needle. The first, the cyclodialysis area of the cyclodialysis is opened. The conjunctiva is open, peritomy being done. 26 gauge bent needle is being passed. Get it through around to go through and through the ciliary body and sclera and come out through 2 mm behind the limbus. Pass a 8-0 proline suture. The tip is passed, so the needle will be outside on the scleral side. Once you have done that, take a bite of the scleral side with the entry wound and pass it through the loop. You basically have to create multiple mattress sutures. And each penetration through the sclera and ciliary body should be 1 clock hour apart. Recoil the needle, pass it again, full thickness, take a bite, come out, pass the needle again through the loop. You have to do multiple times to get a continuous mattress suture so that you get a better approximation closure of the cleft. Once the last suture is passed, the last track is passed or sclerotomy is passed, pull out the needle completely. Yeah. Try the ends of the sutures of the sieving machine suture so that it becomes tightly tightened. Then you have to create another overhand friction knot, which is slightly away from the main knot, which is around 3 mm from the sclerotomy site. Once you have done that, you need to bury this knot now. Take a 27 gauge needle, make a tract around 3 mm in length approximately, make a tunnel tract, and while using a needle, you can bury those knots into this tract which you have created with the needle so that the knot will not get exposed. Okay, then cut in flush with the thing. This maneuver can be done transconjunctivally also without opening doing a peritomy. Here in this case, the same maneuver, but without opening the conjunctiva. Go with a 26 gauge needle, come out through the ciliary body region, 2 mm from the limbus, you can come out. And using the same 8-0 proline needle, same maneuver can be repeated. So one need not open the conjunctiva in all the cases. You can get away with the good cyclopexy in these cases and definitive closure. This especially helps in large clefts, cyclodialysis clefts. similar maneuver. So I'll skip this video because I wanted to show the just transconjunctival technique. So the advantages of the technique which I showed is it's an intrascleral approach, can be done transconjunctivally also. The sclerotomies which are created with 26 gauge needle are self-sealing, so there is no leakage. The clefts are closed from inside to outside manner, so that there is a definitive closure is possible. Does not require a scleral groove or the frap. The suture is 2 mm posterior to the limbus, so it does not interfere with the pars plana incision. Suppose there is a posterior ciliary slippage, the needle can be lifted anteriorly while passing so that you can reposit it much better. So definitive closure is possible in large clefts. Here is another case with a trauma where cleft being identified using an intraoperative endoscopy. You can see here there is a fibrotic membrane which was covering the ciliary body, which is causing traction and the cleft. This is the pre-operative anterior segment OCT, and this is a post-operative anterior segment OCT. This is a hypotonic maculopathy intraoperatively seen, and this is a post-operative picture. Just by removal of the membrane and doing an endophotocoagulation and a gas tamponade brought about the good result in this case. So in conclusion, the treatment of cyclodialysis basically depends upon the size and the coexisting traumatic pathology, whether the cataract is there, zonulopathy is there, iridodialysis is there, or associated vitreous hemorrhage or some other complication is there. Indirect or endocyclopexy is a preferred technique. Vitrectomy with endotamponade is required if there is associated retinal pathology or vitreous hemorrhage or something of the sort. Modified sieving machine techniques or the intrascleral technique which I showed is a very good, shows good results in large cyclodialysis clefts. Choose a technique with least surgical manipulations and a definitive cleft closure. Thank you for your patient hearing.